Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam, or indeed medical advice. Please refer to your college of entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is aspergillosis. So, aspergillosis spores have been associated with building works in hospitals and aerosolization outbreaks. Invasive disease is seen in the severely compromised. Human infection is caused by the Aspergillus fumigatus fungus, which is a spore-forming mold and is ubiquitous in the environment. It's predominantly transmitted by inhalation of spores. Here we have an image of invasive aspergillosis visualized using Grocot's methanamine silver stain. So the clinical manifestations of aspergillosis can be variable. First of all, there is allergic bronchopulmonary aspergillosis, or ABPA, which comprises exacerbations of asthma, wheezing, fever, cough with mucus plugs, and hemoptysis. Then we have chronic pulmonary aspergillosis, which comprises a chronic cough, hemoptysis, weight loss, and fatigue, so becoming much more systemic. And finally, invasive aspergillosis, which comprises a fever, chest pain, hemoptysis, shortness of breath, and in severe cases, you can see dissemination to other organs. The diagnosis of aspergillosis in cases of invasive aspergillosis can be confirmed by identifying typical fungal hyphae in the tissue. Positive culture of respiratory secretions may only indicate colonization if immunocompetent, and invasive disease if immunocompromised. Galactomannan can be used as a screening tool for invasive aspergillosis. The management depends on clinical manifestations. For aspergilloma, colonization of pre-existing lung cavity, surgery is the only definitive treatment. For ABPA, steroids can be given, and for invasive aspergillosis, amphotericin, voriconazole, or caspofungin can be given, and of course these patients will require more therapies, for example on the intensive care unit. Let's do a question. A 45-year-old woman with a history of asthma presents with worsening wheezing, fever, and coughing up brownish mucus plugs. She also reports experiencing shortness of breath and fatigue. Laboratory tests reveal elevated IgE levels and eosinophilia. A chest X-ray shows central bronchiectasis. Which of the following is the most likely diagnosis? So our options are chronic pulmonary aspergillosis, invasive aspergillosis, allergic bronchopulmonary aspergillosis or ABPA, acute bronchitis, and sarcoidosis. So if we think back about what we've learnt in this video, we can see that this lady predominantly has wheezing, fever, and what sounds like hemoptysis, in that she's coughing up brownish mucus plugs. She's got some shortness of breath and some fatigue, but aside from that, she has no other systemic signs or symptoms. So this all makes the diagnosis of ABPA the most likely out of all of these. Thank you for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in future. See you in our next episode.